Thank you very much, Laura. Okay, according to the timing in the Malvern area of Herefordshire and Worcestershire, we're now just about at 9 o'clock, so we'll kick off. Welcome to everybody to this board meeting of Herefordshire and Worcestershire Health and Care NHS Trust. Welcome to our normal board colleagues. Thank you for attending promptly. We have a number of guests today with us, and I'll notably associated with the patient's story, and I'll let Hannah introduce those when we get to that bit. First of all, for those who I've not met on the screen, I'm Mark Yates, chair of the board, and for those watching as well, because I'm sure there are obviously hundreds, if not thousands, of people watching on YouTube as a hit, and I'm sure it'll be serialized onto Netflix. If anybody has any questions following our board meeting about anything really, board members are always willing and able to explain any matters. So if they would like to contact the trust, that's never a problem to try and expand on any issues that you may have or want explanations for. Okay, so apologies today. I've received apologies from our Chief Nursing Officer, who unfortunately has been drawn to a national meeting down in London and is represented ably by one of her deputies, Hannah. Hannah, you're very welcome today. I think also Rob Cunningham is also at a professional, I think it's stroke rehab meeting today, which is seen as really important for us to be represented by the right person. So Rob sends his apologies as well. Jill, is that all the board apologies that we have, please?
It is, yes.
Thank you very much. We have two sets of minutes to authorise or receive comments on. I'll do item number 4 on the agenda first, which is nice and simple, hopefully, which is the AGM minutes, which was held on the 21st of September. Does anybody have any comments or points of clarification on the AGM minutes, please? I can't see anybody raising hands, so can we agree that they are a true record? And again, Jill, thank you to you and the team for accurate record there. Thank you. That then moves us to the minutes of the meeting also held on the 21st of September, which is our last board meeting. Does anybody have any items that they wish to raise or matters of accuracy from those minutes? Again, I'm not seeing anything, and because I think my list says 28 people on the screen. It's a lot, so please use the raise hand facility is the best way of catching my attention. And if I don't for any reason, then please speak up. Okay, looks like those minutes are all approved. Yes, thank you very much indeed. Which then takes us to the action log. If I press the right buttons on my computer. And although I think they all say closed, I think Sarah wishes to offer comment on action 190. Sarah.
Thank you. It's just to provide the board with some update. You'll recall that we had a carer's story and about a carer's experience of services within the trust, which was really positive. And as a consequence, Mrs. Joyce attended the meeting and submitted a public question last time because her experience had not been so positive, and she wanted carers of people with mental health needs, if you recall, her ideas and suggestions. Just to let the board know that Natalie has done that. It is important, obviously, that we recognise that things don't always go well, and I think in Mrs. Joyce's cases, herself and her mother felt they hadn't been well supported. So Natalie met to go through what the issues were in that regard and what we could do about them. So I think a productive meeting. We recognise that we've got examples where experience is not good enough, as well as where experience is excellent, and it's important we learn from both, isn't it? So just to confirm that Natalie has followed that through and that we are committed to making improvements that Mrs. Joyce has raised, and any other carer that wishes to raise any issues with us. And just to remind anybody that might be watching, there is a number of routes to do that. We can make contact through our PALS team. The information for them is on our website. We also have a carers group who would be very interested in hearing any feedback, and we have a youth board, particularly for any young people that would like to feedback on any issues or experiences with the trust. So just to confirm that action is complete, but just to add a little bit more assurance for the board that the issues raised by Mrs. Joyce have been thoroughly considered. Thanks, Mark.
Thank you, Sarah. And it's also a good example of where we don't get things right. We say we don't get things right, and we strive to learn, and we strive to make things better for sort of next time round, or all other people in that position. The three other actions. Say complete. Board assurance framework will be on the agenda today, obviously, as it always is. I know Natasha's coming along for a further update on freedom to speak up, and without any doubt, the thanks were passed to our finance colleagues and department for the great outcome and cooperation we had with our new auditors. So if we could then move on to item. Oh, sorry. Questions from members of the public. I've not been advised of any, Jill. So is that still the case?
No, there aren't any.
Thank you very much. Which then moves us declarations of interest, folks, which all our declarations on the website. And I'll remind everybody, if you have any either declarations that you know of, or if even any potential or any discussions, then Jill's the first port of call to advise or indeed inform. Thank you. Which then takes us to our patient story. And I think the easiest thing to do is hand straight over to Hannah for introductions. Hannah.
That's great. Many thanks. Good morning, everyone. So I'd like to introduce to you Simon Meadows, who's one of the clinical lead physiotherapists with our musculoskeletal physio service, who together with some of the members of the class, who I'll let Simon introduce, are going to talk to us about the new physio strength-based exercise class. So over to you, Simon.
Thanks ever so much, Hannah, and thank you ever so much for letting us present today. Yes, just as an introduction to myself, my name is Simon Meadows. I'm a clinical lead physiotherapist at Evesham Community Hospital, and I'm here today as well with my lead, Natasha Dent, and Kathleen, Martin and Heather. Patients that have experienced the strength class are here as well to share their experiences. Thank you ever so much to them as well. Just as a bit of a background then, strength forms the foundation of function and rehab. So if that's the amount of strength that you need in your day-to-day activity, you need a bit of a reserve, okay, a reserve to be able to do your activities of daily living. As time goes on, as you get with age, etc., that reserve gets less and less and less until it meets that line, and then we start to get musculoskeletal symptoms such as joint pain, muscle pain, ligament pain, etc. So ideally, what you want to do is you want to build up your reserve of strength so you can deal with your activities of daily living. We instigated a lower quadrant strength class. When I say lower quadrant, I mean from your back down to your feet, from May 2022 in collaboration with the local gym. It's an exciting and new initiative for early rehab for a wide range of ages and musculoskeletal conditions. So like I say, when I say musculoskeletal conditions, I mean those your back pain, your hip pain, your knee pain, your foot pain, etc. And it also emphasis on higher loading. So the evidence suggests that we should be in order to get stronger to optimize strength, you should be pushing weights, etc. As opposed over and above, for example, home exercises. We haven't identified any similar classes in other trusts, which is quite interesting. But there might be something out there, but we haven't identified that. And so we wanted to have a look at outcomes, and we wanted to see if this strength class would promote long-term self-management. So the results were that we had just in about over a year, we had 253 patients have been referred into the class. We used an MSK-HQ improvement score, which is a recognised score, which showed on average an average of 7, which was significant. 96% of patients recommended the class after the class. 92% patients planned long-term self-management after the initial introductions. 78% completed the 3-month course. 77% reported reduction in symptoms. And the youngest patient was 19, the oldest is 82, but I think that's just been changed this week. The oldest is now 89. And the conditions will be low back pain, hip pain, hip OA, knee OA, knee problems, various types of knee problems, fractures, and post operations as well. Stories include, obviously, we're going to hear from Kathleen and Martin and Heather in a minute, but stories include an athlete returning to competitive sport. She didn't think she was going to be able to return to a sport after 2 years of low back pain. A patient with 40 years of knee pain that had resolved, several years of chronic back pain greatly improving. That's a patient in their 70s. Multiple patients mentioning that they can manage stairs again. We hope to sort of promote the class to other trusts, also regarding waiting list initiative, advanced physiotherapy practitioners that work within sort of orthopedics and sort of the gateway between physiotherapy and orthopedics. Excuse me. They can refer directly into the class, and so can our first contact practitioners. We're trying to alter the culture a little bit there, so we get more sort of referrals coming through. That obviously the patients that meet the criteria, which bypasses the need for one-to-one physiotherapy within mainstream physiotherapy, so that may sort of offload the pressures that we have within our service as well. So patients are up at the gym. It's out of that medical environment. It falls in line with social prescribing, the NHS long-term plan. It's promoting patient independence. We're hoping to promote. We'll start a class also for the upper quadrant, which is from your the head down to your arm, down to your hand. We presented at the Chartered Society of Physiotherapy recently on this, and we're also writing an article on the class as well. But I'd like to. That's enough of me. I'd like to hand over to Martin, Heather, and Kathleen, who very kindly attended this morning. I think we'll probably, if you don't mind, Martin, can we go with you first, Martin, then Heather, then Kathleen, if that's fine. If you'd like to unmute Martin and kindly share your experience. Thank you.
Okay, thank you for that, Simon. Several years. Simon obviously talked to me about this opportunity to take on this, if you like, a leap of faith for me in the sense of going to the gym. I was a bit sceptical at first. I think the other thing as well is that I would say is that I used to think about going to physiotherapy as almost a silver bullet. They were going to pull me out and stretch me, and then I'll be all okay. And it dawned on me that it wasn't working. And also I came away from the sessions with the photocopies of the exercise you have to do. And you start off doing them, and generally what then happens is, I found, was that you kind of lapse. So then you end up back going to physiotherapy. So the reality for me was that, when you said go to the gym, I was skeptical. I said, well, I've got to give it a try. And that's when I kind of realised when I went there that you only got to help yourself. The reality being is, no matter who you talk to, the only person who make the changes is you. So that was a big dawning for me. Now, what's happened now is I went through it, and Simon supported me all the way through it. I now go to the gym twice a week to do the strengthening exercises, and I've moved on from there now. I also go swimming where I do my, because I had a hip replacement, so I do all the exercises they gave me in the water, including squats. And I also play badminton every Sunday morning at 9 o'clock now. So for me, it's been a life change. So thanks for that, Simon. You've made a hell of a difference. I have to say, I'm heading towards 67, so I still have the lower back pain and I have the dodgy knees, but the reality is I know what I'm doing is actually making a difference. I think it's the best thing that could have happened to me and has happened to me. If I was to offer any suggestions about moving forward, because I do think it should, I don't know, can I just ask, Simon, was this your idea?
Well, it was initially. We had a strength specialist who came to our trust a few years back, and I had a kind of a bit of a light bulb moment. So, because they also mentioned some other research which suggests that elderly patients with osteoporosis are not only safe but in a gym, but can strengthen quite well in a gym as well. It's called the Liftmore trial. And I thought it was a light bulb moment. How are we going to, combine the theory of the strengthening with the strengthening? Oh, let's collaborate with the gym. But it was my own idea initially, but I must admit it's been a lot of teamwork along the way. So without the team, it wouldn't have been possible. So thanks to the team as well.
No, I mean I just want, because to me it's made a difference to me. I don't know what my other colleagues on here are going to say, but for me it really has made a difference. If I was to make a couple of suggestions, one would be in the initial phase, and obviously this is, hindsight's a great thing, but for me, we started off, and obviously because there was quite a few on the classes, which is a good thing, so that's a positive. It meant that I thought you were spread a bit thin. And therefore you kind of showed us what we need to do, and obviously have to crack on, but it would have been nice to have had a little bit more time during those sessions. So obviously, I imagine it's moved on now. You had 253, I think you said, and in that 4 weeks, just extending the time you have by about 15 or so minutes would just give that little bit of sense check to make sure that people really have got the use of the machines really embedded, because that's important, because that also helps with the engaging in the ownership. And I think the other one is that at the end of the period of time when you've completed and you kind of sign us off, which is good, on the exercise sheet that you gave us, we obviously did the ones that you said, and there were quite a lot on there. And I have learned to use the gym people now, but it takes a bit, you have to build up a bit of confidence to talk to them, because you take them the sheet and then they kind of take it and explain to you. But it would be nice at the end of 3 months if you could then go back and say, right, where have you got to now? Those obviously, because obviously not everybody engage, but those that do engage, and almost just have a follow-up session to move people on to maybe the next level, which would then obviously encourage them, but also give them a greater confidence to be a bit more experimental. Just a bit of feedback. But for me, I have to say, I wish I'd done it years ago, and thank you for the opportunity. Brilliant.
Thanks, Martin. And also, just wanted to let you know as well, it is an evolving class. Feedback from patients and staff, everything that we get feedback on, we try to instigate and take on board. But thank you ever so much for that. And can I hand over to Heather? Heather, if you could very kindly unmute your microphone and put your camera on, that'd be great. Thank you.
Can you hear me?
Well, we can hear you.
Sorry, I'm not sure which one it is. Camera, is it?
Yeah, press the
Yeah.
That's it. Yeah, that's it. Yeah.
Can you see me?
I think you've gone off my screen. I can't see you actually, but can anyone else see?
Yes, we can.
Yes,
Okay,
yes,
thank
we
you.
can see you.
Thank you. Thank you. Yes, Heather, thank you.
Good morning. I must say I agree 100% with everything Martin said. My story, I'm 72. I didn't dream I would be doing the gym, but I now do it 3 times a week. The benefit has been unbelievable. I've gone from not being able to stand to cook a dinner to be able to cook a dinner now. I've gone from not to have to sit down to do gardening to be able to stand and do gardening and carry things. When I started, I thought, oh, I'll try the cross trainer, which I used to do many years ago, and I couldn't do a minute. I can now do 10 minutes, and I try to increase it by a minute every week. The weights, I'm really working on the weights, and it's doing wonders. The hip pain is really nearly solved. I've still got lower back pain, but that's ongoing, and I think it's going to improve. I just couldn't, I can't say a lot more than Martin, because he's really covered everything. But I can only say thank you, and please encourage other people to do the same. I have been also, I go 3 times a week, very early in the morning. My incentive is picking my daughter up to go swimming, and I do that, so we have an hour. So I've got the gym instructors to also show me how to strengthen my arms and shoulders. Because I've got knee replacements, you can't go on your knees. So I want to be able to get up on my arms to get up unaided. And apart from that, I'd just like to really thank Simon for everything. Thank you.
Thank you ever so much for that, Heather. Kathleen, are you good to go with the...
I don't know if I'm good to go.
Okay. Thank
Yeah,
you.
the best time I've had this year was started on the 8th of June when I started the strengthening course, and it was just phenomenal. I couldn't believe what I could do. I had lots of support from Simon and his colleagues, and from the instructors in the gym, who always kept saying, Kathleen, you're doing awfully well, keep going, keep going. And even my friends noticed a change in my walking. My blood pressure went down my weight went down. I don't know how that happened. But generally, my general well-being, because I do suffer with depression, my depression lifted. I challenged myself every week with sometimes putting weights on with certain bits of the equipment. And if I couldn't remember what Simon had said, if he wasn't there, about the machines, I would go and ask the young man, and he would explain it to me, and off I went. It was the best thing I ever did. I had come on, Kathleen, think of the word. I had a steroid injection in my right knee, which Simon did, but then I was very desolate because he said I couldn't go to the gym for 3 weeks. By that time, unfortunately, I developed problems with my eyes, and I have problems with my eardrum. And so my depression went down, the exercises stopped. I was encouraged to go back for a recap, which I would have done if I'd felt well enough. I'm not allowed to drive at the moment. But those 12 weeks were the best 12 weeks I've had this year. And I wouldn't have swapped them for anything. And I can't wait to feel better so I can get back again. And it's all thanks again to Simon and his colleagues who encouraged me. Just amazing. I wouldn't have believed I could have done what I did. And so I'm thankful for that. But I shall be back once I feel more like myself.
Thank you so much, Kathleen. I'd like to say thank you for all for listening. Again, thank you to Kathleen, Heather and Martin. I'll hand you back to Hannah, but I'm not sure if you've got any questions or anything before I hand you back to Hannah, or how you want to run this bit.
Okay, thank you, Simon. We obviously have a number of questions, if you can see on the screen there, which I'll come to. But Martin, Heather, Kathleen, thank you ever so much for relaying your experience to us. There is no substitute for ourselves as board members as to hearing directly from our patients. And you've given us a very eloquent example of not only the physical benefits, but also the psychological benefits of some of our therapies. And that's been really pleasing to hear. And also some of the improvements, as Martin articulated. There are a number of questions. I mean, I've got to be honest, I listened to that and thought, I want to go. I need to go to those classes because I recognise those aches and pains immediately. But we'll go through the questions, people on the screen there. So we'll go to Tessa first, and after Tessa, we'll go to Vina. Tessa.
Thank you, Mark. Firstly, I just want to say I'm really pleased to hear these stories here, because I visited Evesham and met Simon. I think it's almost 12 months ago. I think it was December last year. And obviously it was early doors still as to how the service was developing. And I'm curious about how we're going to spread this, Simon, and how we're going to get more classes around the county to make it more accessible to more people, because it sounds like a great success and we need to build on it.
Thank you, Tessa. Based on results from Evesham, we have actually instigated other classes around the trust. We've got another class at Evesham because of demand. We've got another class at Droitwich, and we're also thinking about starting one in Worcester, plus or minus sort of maybe some collaboration with Worcester Acute as well with that one, and also we got a class that started in Malvern, and we're going to get another class started in Bromsgrove as well. So we have been promoting it as best we can, and then also we'd like to try and promote it with the article that we're doing to further afield as well. Thank you.
Yeah, Vina.
Thank you. And actually, that's so inspiring to hear. I wondered, given the clear physical and mental health benefits of these sort of strength-based programs, should we be thinking about making this accessible to our staff as well? Given how physically and mentally challenging these roles are, can we not think about using these sort of programs as preventative measures rather than just limiting it to those who have a condition that need to be treated? It seems to me that in terms of instilling these fantastic habits, several of you talked about, this is now part of your life. Surely that's something that we need to be encouraging our staff in relation to as well.
Yeah, I completely agree, Vina, that everyone should be doing this. It doesn't matter, patients, staff, general public should be thinking about strengthening, because as we get older, over the age of 40, I think it is, we lose 1 to 3% of our strength every year. So everyone really should be in the gym pushing weights. But I mean, our remit at the moment is obviously to deal with our caseloads that we have, and we are stretched as well. But if there was funding, etc., available for that, then that is something which would be a very good idea to do.
Just come in as the service lead. So obviously, staff members can fast track. We have the fast track service to physiotherapy that's offered to all our staff via a management referral. And obviously, if we get a referral in and we think it's suitable, then that member of staff would be given the opportunity to attend the strength class in one of our localities. There is definitely an option for staff, but as I don't totally appreciate it's not specific to all staff, but it is those that get referred to us.
Before I move to Janet, because it's pertinent, if I may jump in, Janet. Of course, we've got nearly 5,000 staff, so when you multiply anything by 5,000, it becomes a headache. But could you say something, Simon, about the partnerships we may have? Because you mentioned the gyms. What type of partnership do we have with the gym providers? Because I know around our county there are some sort of should we call it multinational or national gym players that may at some stage in the future, through discussions, be able to offer to our staff or discounts and things like that. So could you say something about our partnerships, please?
Yeah, at the moment we are partnered up with Rivers Gym, and they've got gyms in Droitwich, Evesham, and where's the other one? Pershore. And so, I mean, and we just approached them to collaborate. And the way it works is that the patients have a discounted rate, so they do pay as you go. And for those that are on benefits, they have 3 months of free access, and then also discounted rates for other services within the other facilities within the actual Rivers complex. But so far it has only just been the Rivers Gym, just because out of convenience. The Rivers Gym is a 9-minute walk away from this hospital, a modern big facility. But I think in Bromsgrove they're approaching another a gym organisation which is different to Rivers. But I mean, yes, I mean you could explore and think about other gyms collaborating as well, if that kind of answers your question. I'm not sure.
Yes, it does. I wondered who we collaborated with, and perhaps I'm looking at Sarah as our chief executive, but I suspect it'd be a reasonable idea for Hannah as a lead on therapies to perhaps liaise with Kate Lee, something like that, to see whether in the long term, these things never happen quickly, but I think Hannah has a conversation with Kate about the potential to source perhaps staff discounts for this exact benefit to our staff, as indicated by Vina. Would that be something you could do, Hannah? Yes, I've got a thumbs up there. So I think that would be a thing to explore, certainly, Vina, because I think it's a great idea. Janet. Oh yeah, certainly.
Janet, just quickly. So you also mentioned about partnership working. So obviously we're keen to work as a system with our partners at Worcestershire Acute NHS Trust, and obviously Worcester City. With regard to physiotherapy, obviously our Crowngate Clinic sees some of the Worcester City patients, but Worcestershire Acute sees a proportion of post-ops for Worcester City. So we are working collaboratively, the two organisations together, which is really great working with regard to the strength and conditioning class that we're going to offer for Worcester City, which I think, going forward, definitely definitely for MSK, it is definitely big advances on what we've seen in the last 5 years with regard to that partnership working. And you know, we are really you know, bought into that going forward, because we know that that is in the best interest of our patients, and to make the efficiencies that we have got to be making in 2023 and going forward. So yeah, I think those sort of partnerships are really important.
Yeah, thanks, Natasha. And your words around our partners is a wise reminder. And I think Hannah and Kate in their discussions, perhaps it's an ICB issue rather than only our own trust as an issue. Janet.
Yeah, thank you, Mark, and thank you, everybody. I found it really interesting. And actually, the discussion that we've just had answered one of my questions, because I was going to raise the issue of could we offer our staff as a benefit reduced cost gym membership, and actually it seems to me as though we've sort of got a bit of an action around that already. So my point was going to be around actually sitting here listening, like Mark. I found it inspiring, and I'm thinking I need to go to the gym. And I think it's really interesting because you read, you can't open a newspaper nowadays without seeing, you should be doing weights over the age of, and this is what you need to do. And I read the articles and I think, yeah, I need to do that, and then I do absolutely nothing about it. But actually, having listened this morning to Martin, Kathleen, and Heather, I'm thinking, right, if they can do it, I can do it. And I'm really thinking of a positive action here for me. And I'm just thinking, actually, they were powerful. Their presentations were really, really powerful. And I do feel that's inspired me. So I'm wondering whether we could actually bottle that, or if not bottle it, then actually video it, and have some videos that we could show people, because I think, we're not alone. We're probably all writing on our to-do list to do something about this. So I wonder if we can actually use the inspiring people that we've heard from today to do that. So that was my thought. But then I do have a question, which is a bit of more of a negative question, I'm afraid. And that is that obviously, Simon and Natasha, you've brought us 3 superstars today to talk to us, who've really benefited from this. But I wondered, what is the dropout rate like? I'm hoping that it's not high, but I just think it's something we should be aware of. Thank you.
Thanks, Janet. So those that start, 78% complete the 3-month course. And then we might, what's encouraging is that 96% recommend the class. So we must be doing something right, I suppose. And then it's not for everyone. 23% of patients don't benefit. It's not for them, or they don't like the gym environment, and then they may have to be managed or supported by within our department and so on. But so it's a good, so 78% completed the course, and 92% planning on going on, carrying on in the gym after they've completed the 3-month course. I hope that answers your question.
Yeah, I think it absolutely did, Simon. It's good for us to have the research to know exactly that. But it sounds those figures are really encouraging, to be honest. I think in any initiative to get those type of figures is really encouraging. Beej.
Thank you. Firstly, thank you, Martin, Kathleen, and Heather. That was fantastic. And of course, thanks to Heather, Hannah, and Simon for all the work you're doing. My question was about capacity and attracting more people. It doesn't sound like we've got a problem in terms of demand. Maybe we've got too much demand, but what sort of capacity do we have currently to take more patients through this process? My next question was going to be, sorry, go ahead, Simon.
So, well, at the moment, you're for a class, it's probably around about, and each class takes 4 new patients into the class. When I say 4 new patients, I mean 4 new to the class, not 4 new patients to physiotherapy. But there's around about a 2 to 3 week waiting list at the moment to get into the class. So it's not too bad. However, if you're going to think about changing the culture and trying to get more people into these classes, then you are going to have to think about more classes. But then it brings on the problem that you need physiotherapists back in the department to look after the patients that need that one-to-one physio that aren't necessarily appropriate to go into the class. And it's also, we need to change that culture as well. We need to you know, the FCPs and app staff, you know, they can refer into these classes if they meet, the patients meet the criteria. So sorry, when I say app, I mean advanced physiotherapy practitioner. They can refer directly into the class. So it's trying to change the mindset, bearing in mind that strength is the foundation of what we do, and also I'm sort of thinking about an idea about sort of fast tracking patients into these classes, which I'm talking to Natasha about, based on information that patients provide on self-referral. So if the demand does go up, then yes, you need more classes, but in order to service those classes, we need the staff to be able to service it. But but it may be that if we use the classes wisely, then it will take the demand off our waiting list, because patients will be going into the classes rather than coming in. And as Martin said earlier, sometimes physiotherapy, you're getting a sheet of exercises, you're getting some manual therapy, which can be, very, very good in certain situations, but but if you really want, results, it's about long-term self empowerment and engagement, in strengthening and taking control of where you're going, for the patient,
Sure.
Is that okay?
Yeah, no, absolutely, and I totally agree with the preventative angle of all of this. It's hugely beneficial. My other point, and it's not one for necessarily, it's not a question for an answer, but clearly diet and nutrition is so closely linked to personal, both physical as mental welfare. And I can't help but think there's probably something more we can do with maybe the same cohort of patients around helping them with their diet and nutrition, and whether we could join forces with both our internal people that deal with that as well as other partners in our system. That was just a thought. Thank you.
And then I see Natasha wanted to come in and offer comment. So I would suggest, I suspect, Natasha, you're well qualified to comment on that as well. Natasha?
Yeah, so the first point just to raise is obviously the majority of the patients that are in these groups are follow-up patients. So they've had an initial assessment in one of our bases first. There are a small number of patients that are going in directly from the referral. So directly from a referral straight, the first contact that we have with them is in the gym, okay? And so we have to manage our waiting lists. And as you know, physiotherapy, particularly MSK physio, is in demand. OK, and so we do have to get that balancing act between seeing our new assessments, the patients that are waiting on our waiting list, and obviously managing our caseload of patients with regard to the treatment and intervention that they have. So yeah, your comment, it is as far as my perspective, it is a juggling act between the resource we've got and that capacity and demand work that we can deliver. We're not a huge service, okay, but we are a county-wide service. So yeah, those discussions are taking place around that.
Thank you, Natasha. And of course, that's a microcosm of the entire NHS, isn't it? Capacity versus demand. I think it's very apt. Martin, you're showing again, and I think it's great that we can finish with whatever comment that you may have as one of our patients. Martin.
Thank you for the opportunity. Just two things really. One is I was just thinking about going back to what I said about the actual gym and having that support. And bearing in mind that this seems to be extremely successful from what I've heard from this morning, and that is, if at the Rivers Gym there was somebody there on a Tuesday morning and a Thursday morning from the physio team, and it was advertised as classes with support, that might help with the growing and helping people to self-learn, and that might help some of the infrastructure. And I know that needs backfilling to obviously the physio department, but that I'm just thinking about that. If that person was there, it's more easy to interact with them because they understand what you're there for and what you're trying to do, than trying to talk to one of those young, fit guys. And you with me? And they show you the machines and things, but they're talking to you, but they know what they're talking about. Whereas the physio guys take the time to explain what you're going to benefit from and don't go too fast. So it's a different kind of approach between the gym guys and the physio guys, if that makes sense, yeah? And then the second thing is really just to give positive feedback, and that is I've lost 8 pounds. So, and I thought I'd share that because the reality is it isn't just about the exercise, because what you tend to do then is your mind changes. Therefore, you realise that you've got to stop stuffing things in, because it doesn't help you to do what you got to do. So that's me signing off. Is that okay?
That's very much more than okay, Martin, because I think you encapsulated the whole benefit there almost in a couple of sentences. And I think what you also reinforced to us is something we've not mentioned collectively here, but the NHS and indeed our ICS is driving towards trying to get towards more prevention, trying to manage our population for prevention so people don't get ill and unhealthy. And this is a great example of that happening. So congratulations to all. Specific thank you, Martin, Heather, Kathleen. Your contributions this morning shouldn't be underestimated by you at all, because as you've heard on the screen, you've on an individual basis invigorated some of us to, and I suspect all of us, to recognise that we all need to do a little bit more about ensuring the conditioning and strengthening of our body doesn't deteriorate. We are all approaching or at a certain age, shall we say. And so we do need to actually think of that. But actually the psychological side, I'm sure all our patients are aware that the other side of our trust is looking after the mental health of our population across Herefordshire and Worcestershire. And this is something that does exactly that. So thank you ever so much for your attendance this morning. And as you can see, your attendance may ultimately affect thousands of our staff as well and benefit them. So this patient story this morning has been extremely beneficial. And thank you for coming forward. I know some of you probably aren't used to speaking to a gallery of people on the screen. And in doing so, you've made a difference. You've absolutely made a difference. So thank you very much indeed. And Hannah, Simon and your team, Natasha, said life-changing. That's the two words that stuck with me. He described it as life-changing. If our activities can be life-changing, there's no better spur to carry on. And so thank you very much, Simon, Natasha, for your attendance this morning. Brilliant. Thank you very much. We'll move on with the agenda now. And we'll move to Chief Executive's report.
Thank you. Just want to draw out some of the key points in the report. As usual, I start with the national issues, and just the one thing I wanted to touch on was the industrial action. So you'll see in the report there's an update around the impact on our services. Actually, internally, the industrial action was managed really well. People were very supportive, and the number of appointments and staff who were on strike was minimised, and services largely continued as normal. But the issue I just wanted to pick up on was that there is an item later on our agenda around the financial position as a consequence of the industrial action, and a request for systems to review the financial plan, because financial plans were done in advance of appreciating that there was going to be so much industrial action over the year. So we've been asked to relook at our financial plan for this reason and a couple of other reasons, and that will be picked up later on the agenda. There's some information in there on the COVID inquiry, which is just to note. In terms of the ICS issues, I just wanted to highlight the oversight framework segmentation, and just to confirm that as it stands at the moment, we remain in segment 2. That's reported through Finance and Performance Committee. In terms of our local partnerships, I do want to highlight the research partnership with the University of Worcester. This is a fantastic piece of work, so thank you to John and the research team, particularly Sam Topping and Peter Langdon, who you all met as a board recently when they updated you on the research agenda. They've been doing some work with the University of Worcester, and we've forged this new partnership through a memorandum of understanding, which documents, if you like, that commitment of both organisations to develop health research initiatives together and look at developing future generation of researchers. So that's really positive. On a linked note, you'll all be aware that Worcester University Medical School opened in September and welcomed 44 students. We as a trust have contributed to the funding of the UK students in the cohort, and there's also a significant international cohort of students who've started at the university. The really good news is that the Secretary of State has announced that from September next year, 2024, that there will be 50 places commissioned from University of Worcester through Core Health Education England funding, which is fantastic because it brings our local medical school in line with the national core funding streams and makes it more secure. So, you know, we will absolutely welcome all our international colleagues, but actually we're really keen to encourage local students who might remain in our geography and over time continue and stay and work with the trust and in our system. So that's really positive. I won't touch on vaccinations because I think we've got a more detailed conversation about that later. If I can just focus then on the trust issues within the report, and particularly the trust improvement plan. You'll all be aware that the improvement plan work was generated following verbal feedback from the CQC following our inspection this year. The improvement plan is being led by Scott, who's with us today. And Scott has been conducting a substantial piece of staff engagement work, which is actually really, really positive. We've now got over 580 staff who've directly engaged in this, either through individual conversations with Scott or through events, workshops, or attendance at team meetings by Scott and a couple of other members of the team. So I do want to thank everyone who's joined in that and contributed to it in terms of our staff group, because that's been really helpful. And through that work, we're picking up some positive feedback and we're picking up a number of areas from development. And what Scott's doing at the moment is collating that feedback, which will come back to the board and will inform our programme of cultural reset. So we're really keen to listen to what staff have to say, what they think needs to change, and that will inform our next steps. You'll see in my paper it covers the 3 key themes coming out of that feedback and reset around compassion, adjust and learning, becoming a learning organisation, and being trauma informed across our support for patients and staff. And also what's coming out strongly through this work is some underpinning thoughts about behaviour that we need to underpin our core areas of focus and our priorities as a trust. And some really interesting areas coming out here, which are in the report, around being person and patient centred, being compassionate, being transparent, being honest and truthful, which I think are really important and very strong words, collaborative and accountable. So I think that's really fantastic that we're really starting to galvanise now with all the comments coming together into some really key themes. So what's going to happen next? We've already got the 3 work streams that are part of the improvement plan that the board has seen. They are already meeting regularly to work up their part of the plan and make sure it's implemented. And that includes things like simplifying our processes and our structures for staff. So those work streams are continuing to roll. There will be some commissioned external work as a consequence, particularly around the cultural reset and potentially around the EDI element of our plan. You'll all know, I mean, as a board, we've talked about this before, and we've all absolutely committed to making the changes that need to be made as a consequence of the staff feedback. Really, really important now that we have heard staff, and we need to therefore seize the moment and make some changes on the back of that feedback. Really important to staff that we do that relatively quickly, as you would imagine. One of the things, and maybe we could come back to it at the end of the report, Mark, when I finished, but one of my reflections was that we were originally thinking that our vision and values potentially needed refreshing, and that the right time to do that would probably be next spring, summer, when we were also doing the strategy refresh. But personally, I'm now reflecting on the staff feedback that Scott's sharing, and I actually feel it'd be a bit foolish to lose the moment. We've got all this fantastic feedback from staff, and what I don't want is another list of behaviours and values that is different from our core trust values. So I'm really thinking now, and this is a change to timing of our previous conversations, I'm thinking, given we've got all this fantastic information coming forward from staff, that we should probably seize the moment and proceed now with that refresh of our vision and values. I think timing would still work. It would still lead into the strategy next spring, but I'd be really interested for board views on that when I get to the end of the paper, just so that we can think about, is that what we want to do? Do we just want to press on now? Because I think otherwise we're going to end up with a couple of disjointed pieces of work. So really important it flows. Do you want me to pause on that now, Mark?
Yeah, I think it's a really important matter. So if we pause there and then seek views on exactly what Sarah said there. Janet.
Yes, thank you. I would absolutely agree with that, because I think if we don't do that, we will inevitably end up going out to staff again and asking them again. And what that will reinforce is some of the other feedback we've had from staff, which is you ask us questions all the time and then you never do anything with the information. So I completely agree with Sarah. I think we use this, the time is right, we capitalise on it, and actually we're all enthusiastic and keen about doing this, so let's get it done. So that would be my feeling.
Thank you, Janet, and I notice a lot of nods around the screen as well. Martin.
Yeah, thanks for that. And yes, Sarah, I absolutely 100% agree. I think the other perspective, though, is that you can't do trauma-informed care on an island, and it relies on a continuum of care across all our partnerships. So we need to make sure that we are moving much more towards integrated values, integrated vision across the system, and the quicker we get on and do that, absolutely the better, and that will help strengthen the whole approach.
Thank you, Martin. And I think Sue will comment next. And if there's nobody better place to talk about the joining up of strategies and across the ICS than her, Sue.
Yeah, and I think this is really timely, and we've been hearing a lot about responding and being a learning organisation. So it is really important that we hear the 500 people who have said our vision and values, and subsequently the behaviours that underpin that, we're not quite where we would want them to be. So we could move into that space immediately because we've got the feedback. What I wanted to flag as well, though, is I don't think our strategic objectives change hugely. So a lot of what we've got in terms of our focus on health inequalities, the improvements around quality, being a fantastic place to work, they still feel very relevant. So it wouldn't be almost an overhaul of our trust strategy. I think it's taking a bit about culture, responding now, and then continuing the journey with the strategic objectives on what we want to focus on. And so that narrative seems to flow for me, and also then speaks very much into the system space, because actually we're in the annual planning cycle now, and therefore we could mobilise this now through the remainder of this year and then be really ready to pull something through in the April time next year. So I think the timing's fine, and I just think we don't want to lose sight of the strategic objectives still being current, but actually it is the values and the behaviours that need to be refreshed.
Thank you, Sue. Tessa.
I agree completely that we need to grasp this and do it. I think that the absolutely most critical thing is telling staff what we're doing and why we're doing it, and making sure that it is absolutely front and centre, that we're listening to them, because as we move forward with all the cultural shifts and the workforce people plan, we need to make sure that people are still willing to talk to us and keep talking to us, and we don't want them to switch off with there's too many surveys and nobody's doing anything. And I do think the piece of work that needs to underpin this is knitting all of that stuff that falls below. And I know Scott's already responded to an email from me this morning about how we make it all knit together, and hopefully that will start from the extraordinary workforce committee and quality and safety committee in December, to make sure all of our plans are coming together and pulling in the same direction, because I think there is a risk that we've got so much on the agenda that things fragment off and get forgotten, and I think that would be a mistake.
Thank you, Tessa, and probably come to a conclusion with Carol.
Yes, thank you. I was just going to pick up on the system point, because I would like to think that wherever you are working in the system, that you can demonstrate consistent values and behaviour, because that makes it easier for our staff, it makes it easier for us to integrate, and it just improves that collaboration if we're all working from those same broad principles. So I'd really welcome that, looking at it at a system level.
Yep. Thank you, Carol. And just, if I may say so from the chair, we need to remember, all of ourselves personally on the screen and collectively on the screen, this is about us as a board more than anything else in a way. We must collectively and individually demonstrate the behaviours. We must collectively and individually live the values, and recognise that one of the reasons why we have an improvement plan developing and in place is because we therefore evidently haven't been as effective as we should have been in the past. And collectively, I know that we want to be more effective as the most senior leaders in the trust, collectively and individually. And that's why we're going through, outside of these, a formal board meetings, we have development sessions collectively, and we need to remember that. And I think it was our chief medical officer originally, maybe 3 or 4 months ago, that reminded us, I think, at one of our meetings that this is about us as well, if not more than anything, and we need to be more efficient for our patients, for our public, with the rest of your report.
Thank you, that's much appreciated. I think keeping the momentum going will be really positive, and it will also enable us, as we're working with an external partner, to build this piece of work into the work we're doing with them and get their advice and guidance as well. So thank you for that. We'll take that forward. Just in terms of other trust issues I wanted to draw out, you see the information on the Workforce Race Equality Standard, which will come through the Workforce Committee. That report referred to a 5-year period of data, which needs some scrutiny, and you'll see in my report the areas for improvement, which were the likelihood of entering formal disciplinary procedures, discrimination from a manager or colleague in the last 12 months against BAME staff, and board representation. So, and our areas of best performance are also noted there for your information, which is the likelihood of appointment from shortlisting and career progression issues. Of note, just to highlight to the board that Natalie has been invited to join the NHS Employers Policy Board, which acts as a critical friend to NHS employers around a whole range of workforce issues on behalf of employers. So really, really positive for us as a trust that Natalie's been asked to join that board, and she will feed back in due course. In fact, we might want to just think, Tessa, offline about how you want to make sure that feedback comes back to Workforce Committee and we don't lose anything there. You'll be aware we had a focus on speaking up in October because it was Freedom to Speak Up month. And Natasha's done a number of workshops and reminders to staff, and continues to do quite a few outreach sessions to increase awareness. Brief update on non-exec director appointments, just to formally note in the minutes that Carol has been appointed by NHS England as non-exec director with effect from the 7th of November for a 3-year term, and that Carol will chair the Mental Health Collaborative Committee, and Sue Hinks is the assigned non-exec lead overseeing the implementation of the PCREV framework, the Patient and Carer Race Equality Framework. We did note thanks to Jamie at his last meeting, just to formally thank Jamie, who's now concluded his term of office, for his massive contribution. And finally on here, just to highlight that we have been shortlisted as finalists, as I say, the Royal Way. Members of our staff who've worked really, really hard on the apprenticeship programmes have been shortlisted in the Worcestershire Large Apprenticeship Employer of the Year Award, and also for some individual awards at the Worcestershire Apprenticeship event. The event, I believe, is this evening, and I think, Tessa, I think you might be attending this evening to see how successful we are. So in due course, we'll feed back to that, but it's fantastic that we've got a number of staff shortlisted on such an important topic area. And we have over 170 apprentices now in the trust at any one time, which is a huge kind of positive symbol of our commitment to the apprenticeship programme. So that's really good to see. Thank you, Mark. I'm happy to take any other questions.
Thank you, Sarah. Any questions? Anybody? Comprehensive report with lots of information. Sue.
Yes, may I go back to the university point, and just 2 things. One, will we see the impact of doctor medical students in the trust? Will they get placements with us? And secondly, elsewhere in the papers, I saw that there was an issue with their nursing programme, and that was maybe not supplying us in the way we thought it would. And I just wondered if you could elaborate on that.
Yeah, I mean, overall, the university actually is a fantastic partner. And if we feel the programmes aren't meeting our needs, they're really receptive, really keen to listen and really keen to adapt. I think there are some challenges, and Natalie would say if she was here, there are some challenges around whether they can fill the places available, which I think is a challenge nationally, as we know. So we need to work together to kind of make it a very attractive training institution and do everything we can to attract people to the local area. As a university, training nurses and medics, they're very committed in making sure the community and mental health part of the curriculum is as strong as it can be. So that's another real positive for us in terms of their approach overall. John might want to come in on the specifics. One of our worries this year was that obviously because a lot of the students were going to be international, that whilst they would have placements with the trust, they probably wouldn't work with the trust long term, although some may well do, and that would be really welcome. So we welcome the fact there's now Core UK funding as well, and we can therefore hopefully have more people who might stay in the area. That one of the challenges is that the way some of the training allocations happen, you don't necessarily doctors in training don't stay in the area anyway, but it should increase visibility of what our ICB and our ICS area has to offer and hopefully encourage that interest. But John, do you want to add anything specific on that?
Yes, from the third year onwards, they will have community placements both in our community services and mental health services as well. And I think our medical school has been very much community focused because that's been our strength. One of the things I'm quite optimistic about is the quality of the placements we offer, because most of the consultants we have are usually homegrown, who have trained with us as undergraduates and postgraduates. So I'm quite optimistic, but I think we also need to meet the challenge of providing high quality, good experience placements, especially with the workforce challenges we have. So that's a fine balance we need to tackle.
Thank you, John. Tessa.
Just wanted to make a comment in relation to Sue's question about students working with us, not medical students, but actually from the nursing perspective. Natalie shared quite a lot of detail at Workforce Command, looked particularly at the fact that their attrition rate for students dropping out is higher if they're selected directly by the university, but where we're involved with the selection or their internal candidates going through, the dropout rate is much lower and we get a much better output at the other end of the training. So there's a lot of work being done to look at that and ensure that we do get best value and that students get really good placements when they're with us, so that we can encourage them into our services. And that's particularly around nursing and nursing associates.
Thank you, Tessa. And just to ensure things end up in the minutes and are indeed in the public arena, because Sue, your comment can't be seen in the public arena, I don't think, because it's on. But it's to update board that the One Herefordshire Partnership has been shortlisted for the Health Service Journal Place Partnership Award, which is an accolade in itself, and Sue will be representing us at that award ceremony. So there's another recognition of the work that we do with partners across Herefordshire. Okay, thank you for that report, Sarah. If we can note that and move on to the next item, which is the Board Assurance Framework. And before I hand over to Jill, to remind colleagues that at the end of the meeting we'll be revisiting the Board Assurance Framework to check if there's anything we've heard or discussed today that changes or increases risk or lessens risk, or anything we should be placed within the Board Assurance Framework. Jill.
Thanks, Mark. I'd probably just start off by following on from what Sarah was saying in terms of the work in the improvement plan, that ensuring that appropriate risks are being escalated and people are managing risks at the right level in the organisation is a key piece of work at the moment. Some of that is being supplemented by work with Good Governance Institute, and they're doing a number of activities with us to, one, give us some external assurance about our processes, but also supporting us in terms of reviewing our risk management strategy, which feeds into the review of our risk management strategy that will be fed back to Audit Committee next month, and also some additional training. So the processes of risk management throughout the organisation continue, and the real focus at the moment is making sure that, first of all, risks are appropriately articulated, because I think we would probably recognise that we have quite a mixture of some things that are probably issues as opposed to clearly articulated risks. and secondly, that they're being managed at the appropriate level. And so we've got a workshop next week with service delivery unit leads, and Matthew and Tori, who's on the call, is also joining that, because a key part of this is about how we, through our governance systems, look at risk management. And we make sure that we are looking both backwards in terms of things that have happened to inform risk management, but also looking forward as well. And so that's a key session next week that we're doing with SDU leads. What you have before you in the papers is the board assurance framework, which identifies the key risks to us not achieving our strategic objectives, as well as the high level risks. We, as part of the work that we are doing at the moment, we're systematically working through the higher level risks with risk register owners. And so over the next couple of months, I probably would expect some of those to change, because we're doing some individual detailed work with the authors of those to see as to whether they are properly articulated. And so at the moment I recognise that it is a work in progress. Obviously the board assurance framework, I have identified the updates in red font to hopefully make that easier for people to see the changes. I think at that point I'm happy to take any questions, because I recognise that this is a little bit of a work in progress.
Thanks, Jill. Sue and then Janet.
Yes, no, I recognise also it's a work in progress, and just to sort of highlight that, so the risk 1359 about the MASH, it's very difficult to understand why that is a new risk. What has happened is to put that back on the board assurance framework, and there are some other risks which are much better articulated, where you're given really a cause and a consequence, whereas there you're just left, well, is there a staffing issue there, or is it the police role that's changed that's made it difficult? What's going on? And please, will the clinicians excuse my lack of knowledge of pronunciation? So is it dysphagia or dysphagia? But that's mentioned twice. And in both times the severity and likelihood is 4, whereas actually from what you then read about the risk to respiratory conditions or morbidity for older people, and then for maybe children under 12 months, how their feeding might be compromised, you do sort of think that is actually a very great risk, because in terms of long term that could have a real impact on individuals in a way that some of the other risks seem to be just more sort of superficial, and that's probably not a very technical word, but I do feel when you read this, you're on a bumpy journey. Sometimes you read something and you think, yes, that makes complete sense, and other times you risk it, you read it, you don't understand it, or you think, I actually think that's been downgraded, because if that was my child, I would be thinking it was much more than a 4 in terms of severity.
Before we move on to the next question, I think, can somebody just give a response on that, whether it be from a risk management perspective, and Jill, or whether it be from a clinical perspective, and sort of Matthew or John, perhaps?
I mean, I'm happy to comment generally from a risk management perspective, and then Matthew can perhaps give the details from an operational perspective, because I think that's a classic example of, on the face of it, it would be catastrophic, and therefore I would expect the impact to be a 5. However, the frequency, I'm not aware that has actually happened, and therefore I would probably expect the impact to be possibly a 1. And so I think that we need to be better articulate exactly what the risk is, and whether it's something that should be organisationally managed and therefore on the high level risk register coming to board, or whether this is something that's very specific and is a service specific issue. So that's in terms of the principles of risk management, but perhaps Matthew might be able to comment operationally.
Yes, thank you. So in both of those cases, the risk is written in such a way as, it's the nature of risk, isn't it? Risk is the likelihood of something adverse happening. Now, in both of those cases, we're not able to identify that adverse events have actually happened to individuals that have led to, severe consequences, because mitigations are in place for alternative provision for those services for people that would have the highest impact if the risk were realised. We also score the risks around an impact matrix. So to score a 5, you would the outcome would have to be death of an individual or major life-changing injuries and things like that. So because of the mitigations that are put in place around those individuals that would be at the highest risk of being impacted, that's why it's scored at a 4 and not a 5. If it was completely unmitigated risk, then yes, a 5 would be a better rating for it.
Thank you, Matthew. And I think that's an articulation of where this isn't an exact science, is it? And where we're trying to manage and learn as we go along. Is that okay, Sue, or did you have something else?
Well, I suppose, I mean, obviously numbers are you need the narrative to understand the numbers. But I suppose often that would be articulated as a residual risk. Once you've put the mitigations in place, it would be this. But when you're looking at, when it's saying 4 is a likelihood, is 4 a likelihood before the mitigations are in place or after? From what you're saying and from the level of frequency, it's not really 4 as a likelihood. So it's not really something once the things are put in place and given the frequency of this condition that we have to be worried about. So I suppose these are all discussions that will take place as we sort of refine our processes.
Thanks, Sue. We'll move to Janet.
Yeah, I suppose I'd got a similar comment really, which was around the importance of consistency across the risks, because when you read these, as I think Sue has noted and Matthew, they're very different, aren't they? But it's actually trying to get some sort of consistency of what actually is considered a risk that comes to the board. And I think that's difficult, and completely agree with Jill, it's a work in progress, but I think it's what we should aim for, because else we have the discussions we have. And then the other comment I was going to make was around the level of detail that's brought to the board, because again, I'm aware we discuss risks in our various subcommittees in more detail, and we actually have more detail than's here. But it's actually trying to get some sort of agreement as to what level of detail needs to come in this paper, so that we don't have to have the discussion that we've just had, which was actually around teasing out detail. So we need to, if we look underneath the lines here, some, as Sue said quite rightly, are very detailed with numbers and all sorts of things, and other things just have a sentence. So I think that we need to get the consistency and the detail right. And then the other final point I was going to make was around 1055, which is the ADHD service, which is, I don't want to go into the detail, but that reads to me as though that's quite out of date, considering some of the discussions that we've had. So more power to your elbow with this one, Jill, because I think it's tricky. Get it right, it'll be really beneficial.
Thank you, Janet. Before I move to Carol, I think in discussion between Martin, myself, and perhaps Jill, I think there might be a point where the audit committee can have a bit of a deep dive on the process. It's not the detail, because that's in the operational arena away from the audit committee, but I'd like the audit committee's view on the processes that surround the BAF and whether they're operating properly and whether they're delivering what we think they should be delivering. And I think it might be an audit committee process to do that. Carol.
Yes, I was going to really pick up on 1055 as well about the ADHD one, because if I was reading if I was a member of the public reading those papers and that affected me, to see it dropped under reputational risks would feel wrong. And I think there are some broader issues around that. So we don't need to discuss the topic today, but I think it's that principle of where they show up and how we reflect them in our risk framework. Thank you. Thank you.
Sue, and then we'll conclude with Martin. Sue.
Sorry, this is just a part of my induction. Can one see other boards' BAFs? Are they publicly available, so we could compare if we were trying to learn? People are nodding, so I just need to Google maybe.
Yeah, just for your information, Sue, they are all available. And if you've seen one BAF, you've seen one BAF, because they tend to be very different and in very different ways. But there is lots of learning, and I think it's fair to say Jill has trawled the country to look for good examples. We've been directed by some of our external audits to direct us to places, and it looks like the reality is all BAFs have a part good and a part difficult to understand, and trying to pull the good bits has been extremely difficult. And I think this is Jill's version of trying to herd the cats of the good practice around BAF, I think. So, but yes, they're available for anybody to look at. And if anybody has or identifies any good practice across BAFs across our colleague trust, then please bring them to the attention of Jill. I'm sure she'd welcome it, because any help in this area is always welcome. Thank you. Martin.
Yes, thank you, Chair. I was just going to pick out, because I realised I put it in the chat, which isn't available, and I think the point to pick up with the audit committee and risk 1360 exemplifies it absolutely clearly, of a mixture of an issue which should have a recovery plan associated with it, and then the residual risk. And in the risk register, we should be recording the residual risk, which wouldn't be at the board level for this particular one, but the issue should be at Q&S around the recovery plan if it meets that threshold. And so I absolutely agree with you. We can pick up in audit committee about really clarifying that distinction, which I have to say every board I've ever reviewed has got that issue associated with it.
Thank you, Martin. And of course, this can easily come over a dry subject, but of course, it's the very essence of what we do as a board, isn't it? Is to identify and manage our risks that could affect our priorities of delivery of our services. And so this is something we continue to look at. Thanks, Jill. Can we, colleagues, can we approve the BAF as it stands today in full recognition that it is absolutely work in progress? Yeah, I think there are nods all around the screen. Thank you ever so much, Jill. And now we move to Sue with update on our priorities. And Sue, please accept that we've all read the paper, because there's a lot of information. And if we could just focus on the bits that you need to highlight to bring the board's attention, please.
Yes, thank you, Mark. And as you say, I wasn't going to labour the point. We've got the paper, there's a lot of information. This layout is continually being reviewed now that we've got the enhanced PMO approach, and that means that we're really trying to get into being much more specific about measures and metrics and deliverables. That's certainly the area I wanted to highlight about the attraction and retention piece. A lot of PMO support going into that space at the moment to be really clear on the scope, the deliverables, and then the work we're doing next is on the trajectories. So I know that's been picked up by workforce, but obviously from a board point of view, it is one of our key areas of focus. So putting a lot of PMO capacity into that space at the moment. And the other piece I just wanted to highlight was the clinical model for the adult mental health inpatient services. So we've done a review of the work streams and the timeframes associated with that. We've got to align that to the NHS England service change process. So I'm doing some work with the team and with NHS England to understand the timeframes and the impact that they have in relation to going to clinical senate, for example, and out to public consultation. So I'll pull more information through to PMB, and then that will escalate back to Trust Board in due course. The community mental health transformation is really interesting. I do appreciate there's more on that. And I wanted board to see that, because we're coming through to the end of the sort of 5 months remaining period for the community mental health transformation. We know we did it across 2 phases, lots of learning, some really great integration with primary care networks now in some areas. So we need to think how we're going to scale that up. Increasingly, that's business as usual, but actually it's very much in line with the Fuller report. It is about how do we really move into health inequalities, population health, and that integrated team of teams. And for us in mental health, we've often had community services sitting further back from the physical health agenda. And I think what we've seen through this programme is a real integration of physical, mental health into the primary care network space. Lots of work to do, but it is a really clear example of where we as a board have committed to moving forward with the Fuller principles and how we want to make sure that that's meeting population need and we're not working in silos. And then finally, just to highlight that the IAPT transformation, so the talking therapies work, which again we've talked about at board, been a challenge for some time. That transformational work is complete, and now it's absolutely about sustaining the performance and the deliverables associated with that piece of transformation. A really rapid turnaround actually in relation to what needed to happen and the work that's happened throughout the service, and I wanted to thank the team really, because they've really responded very differently to thinking through their processes, some of the way in which they work, the allocation of tasks. So it does show that when we can put the programme support in and we can get under the bonnet of some of this, we can make changes quickly, and that's going to be really important as we remain agile as a board to get in earlier to resolve issues as they arise. So that's probably the headlines I wanted to pick up then, Mark, and obviously I can see I've already got some hands up.
Yeah, thank you. So we go to Martin, then Veena, please.
Thank you, Sue. You know, I'm a real fan of the home first approach and reducing inequalities and population health. I just wanted to check where we're talking about the Cascade 3D tech, that is not causing any additional health inequity in the terms of the provision, and that doesn't become a barrier to some people accessing the home first approach, and that digital is being used in a positive way, not a negative way, and we're properly evaluating that. But perhaps it's Lisa's to pick that up. But
I think there's a lot of work that we need to do around that area, Martin, and bringing our data colleagues online with pushing the pop health and the home first. But there are lots of work to do in that area.
I'd love to pick that up with you outside the meeting. I'm very familiar with it being used in a social care setting, but actually some of the issues are moving into a healthcare setting are quite complex.
Yeah.
Thank you.
Yeah.
Veena.
Thank you. Sue, I wanted to ask about the IAPT transformation work you've done. And I noticed that the leadership development training, the kind of components of that look very, very similar to the training that we're about to roll out as a result of our improvement plan. And you've said how effective it's been for IAPT. I was just interested to understand, how do we know it's been effective? And if it's that effective, should we be feeding that into our improvement plan work?
Yes, good points, Veena. And as you say, we're a large organisation with a lot happening. So where we see pockets of good practice, which has happened with PACE, we do need to think through how we share and develop that further. So I'll pick up that piece about the component parts and make sure that feeds into a discussion that we're having around the leadership programme next Friday, which Scott's convened. Matthew, do you want to talk a little bit about your experience of this piece of work and what you see as some of those positive pieces?
Yes. So the aim of the work really was to ensure that leaders were leading in a consistent way. And it was very much bespoke around the set of skills that these particular clinical leaders needed in this particular service. In terms of the kind of evidence of outputs, I mean, the evidence of the outputs is that staff are having consistent clinical supervision delivered in a consistent way. Staff are reporting better satisfaction at work, better feeling of being supported by their line managers, greater feeling of personal effectiveness. And that's moved through to clinical outputs as well. So we've got those staff that are being led by those managers that have had the leadership training, achieving greater productivity, greater throughput, where they've had skills deficits, actually having those addressed with bespoke training for themselves. And we've improved patient outputs as well in terms of time to recovery becoming more consistent, and also in Black and minority ethnic patients now having the same recovery rates as white European patients. So it's been a cascade of things that's resulted from that leadership improvement.
Thanks, Matthew. And then Robert, and then we'll conclude with Sue. Thank you.
Yeah, thank you, Chair. Time it's on talking therapies as well, and I suppose it was just to be really clear about the context on talking therapies here and what was in this part of the improvement programme that Sue's referring to. Talking therapies is an absolute national priority, which you'll all be aware of and noted in the performance reports later. This was about us being in a good position in terms of delivering on some of the actual waiting times metrics within that. There is still a huge challenge that remains in terms of overall access, and this is one of the key metrics for us in terms of our segmentation. And those of you at F&P will recall we need to produce a recovery plan around actually, are we achieving good, effective and efficient use of our resource to deliver the access that we should be delivering. At the moment, we're short of that. So absolutely great progress in terms of some of the waiting times measures in terms of the service and the recovery rates, but we've got another significant challenge in terms of the access part, which we're a significant contributor to the overall system on. So just needed to make sure everyone's aware of that.
Thank you, Robert. Sue.
Yes, it's just a question of detail. On the ARISE programme, it says that there can be a 5-month lag for recruiting ACPs because of notice periods. But when I went on the NHS sort of notice period matrix, it said that even people at senior level 7 to 9, their notice period is 3 months. So I just wondered why it's taking 5 months, or am I missing something?
I don't know if that's going to be Elaine or whomever would respond to that, because it's not just in that area. We have concerns around the length of time to recruit. So who could offer comment on that? Matthew, is it Matthew?
Yeah, I'm probably Elaine may be more best place, but the reason is because that people do not give their notice until they've had their unconditional confirmation of offer from us. So that can only be completed once a number of internal mandatory processes have also been completed. So that's what takes it through to from the statutory 3 months out to 5 months typically.
Yeah, I wasn't going to be able to add anything different to what you've just said, Matthew. Yeah.
But can I ask, because we know that this is an issue for us, can I ask what we're doing about that, please? Because I know it's examined in workforce, because some of those mandatory things can be done as part of the recruitment process leading up to interview, and I'm led to believe there are initiatives to try and lessen this. Is that correct, Elaine?
Yes, we have removed the conditional offer letter. We've moved straight to unconditional and working through looking to expedite that a lot quicker than we've done previously. So that has taken off a few days, but it is, as Matthew said, the case of people aren't putting in their notice until they've gone through that. We're hoping it's about them returning paperwork much quicker as well. So we're looking to automate that similarly. But logistically, we're doing all that we can to reduce the time. But it is about people waiting for that final letter as a matter of safety rather than anything else.
Thank you, Elaine. And I feel sure Tessa's going to give comment from a workforce committee chair perspective. Tessa.
Yeah, I think as Elaine knows and you know, Mark, this is one of my absolute frustrations. And I think that, yes, there are some things that legally we have to do and processes we have to follow, but I am absolutely convinced that there is more scope for us to shave off time, whether it be days or weeks. I think there's opportunity to learn from other organisations, and I do think that there are some best practice things that we ought to be doing and modelling that don't always happen. So I'm assuming, Elaine, that this will be picked up in the ARISE work stream,
it is,
and
yes.
I think that needs to be a focus of our attention at the January committee meeting, to ensure that all of the actions are being taken forward.
Thank you. And I know that Tessa keeps a focus on that exact issue in workforce, and I know that Elaine feels the heat sometimes around that from the workforce committee. Okay, thank you, Sue. And I do know that this paper will continue to develop, and boards are going to have to use the rolling on and rolling off as we see priorities diminishing and priorities rising. We need to come to some decisions about how long things stay on there and the new things that come on. But Sue will bring that forward later. It was a conversation Sue and I had on the train yesterday. Okay, if we can now move the next two papers, and I'll ask both colleagues, both Matthew first and then Hannah, to ensure that they bring to our attention what needs to be known rather than the entire paper as we've read them. Matthew.
Okay, thank you. I'll try and be brief. Just around EPRR, people know that each year we're assessed against national EPRR standards. It's deliberately an increasing level, so it's more challenging annually. We've been working hard on improvements this year following our disappointing rating last year. We've had our ratification meeting with NHS England, and we've seen a significant increase in our compliance against a higher level of evidence standards. We've achieved 86% this year against 58 elements, which is through to partial compliance. And working with system partners this year, because a lot of the standards now are systems based, and we're confident that we will achieve a further 3 standards up to fully compliant this year, which will raise our level up to substantial. Bit of system news, that obviously the new emergency departments opened at the Worcester Royal Hospital. Been involved with system partners in preparing for its opening, with a number of events to improve hospital flow and prevent emergency department admission. And we identified as part of that mental health patient issues can sometimes play a part in ED flow. So as a result of that, we've got a senior mental health manager involved in the daily system silver calls now. Good news for our frailty virtual wards, which provide assessment and intervention to people who are at risk of hospital admission in the community. We've completed a local evaluation now, which has been shared with system partners. And the evaluation has shown that the Wyre Forest team, who were the first pilot team in Worcestershire, are in fact extremely effective at preventing hospital admission for this patient group. So 75% of patients who went through the Frailty Virtual Wards team remained at home up to 30 days after intervention. Enormous health and psychological benefits associated with that. It's a cost-effective model as well. There's a lot of wasted downtime in hospital, not so much in the community. You're just getting the intervention you need, intensively or less intensively as you need it, and ensures acute hospital beds are available for those who need them most. In fact, if we did roll this out across Worcestershire, a very conservative estimate would be the freeing up of one entire medical ward. Interestingly enough, locally, we're at least as effective as NHS England benchmarking models. Obviously, a small sample in this case, but just for people's attention as well, this is the second innovation in this area where, after our urgent care response service, which has exceeded national targets. As a national benchmark, and actually we've done significantly better than that. And this supports data locally as well, and that conveyance to emergency departments in Worcestershire is below national benchmark. It's less than what you'd expect for this population, which I think is a further testimony to the effectiveness of our community services. And we're ongoing discussion at the moment with system colleagues about the rollout of funding, but we've secured interim funding to start rolling out next to the Vale of Evesham's, the BBI area. Obviously challenges with the system financial position because it's additional, it doesn't necessarily release other funding straight away. And of course, the speed of recruitment. So as we bring these teams on, we have to attract more nurses, therapists and support workers into them. On Hillcrest, we're continuing our stakeholder engagement around the future of Hillcrest Ward and our proposal that we'd like to bring that service into Athlone at the Elgar unit. Obviously, these discussions are based on 2 quality concerns that we can't improve. One is around the built environment at Hillcrest. very complex internal space, very difficult to provide acute care there. And the isolation of the ward, it's the only ward on its own, unsupported by the wards around it. And we've been out to our local communities in Malvern, Kidderminster, Evesham, Redditch and Hereford so far, Worcester City coming up, canvassing views of local people about these changes. Interesting, reasonable feedback so far, which we're collating. The main has been from Redditch in terms of concern about increased travel times for carers and relatives visiting. We're continuing to engage staff around their preferred options for the future as well. So far, the majority of staff we've spoken to working at Hillcrest wish to stay at Hillcrest, and some are unable to travel to Worcestershire because of personal circumstances. But we're continuing those conversations, and they will set the pace along with any public consultation that we're required to undertake around any transfer of functions. So we're still talking about a very, very earliest date of mid next year, likely significantly longer than that. Our best hope for the completion of this programme is that it will align with the outputs of our GIRFT work around mental health rehabilitation beds, and that we can arrive at some accommodation where we're using the Hillcrest ward most effectively, but obviously that's subject to the completion of the GIRFT work. An unexpected outcome and a welcome outcome has been the spontaneous expression of high levels of satisfaction now amongst staff working on the unit. We've had emails following this as well, which was very interesting, and a view from them that we could now open up to more patients. This wasn't asking the staff coming to us and saying, we're comfortable with how this is running now, would like to open up more. And a proposal will be coming shortly to our clinical and professional advisory group, proposing that we increase to 14 beds on Hillcrest from the 10. So that's synopsis of my paper, and happy to take questions.
Thank you, Matthew. Martin and then Sue.
Thank you, Matthew, and great to see the evaluation of the frailty virtual wards. I just want to check in terms of our views on the interim funding for rolling out to Evesham and whether we are going to recruit that on a permanent basis and back ourselves and back the model. We're never going to achieve left shift is our stated aim at ICB unless we do that and have the discussions or lively debates with our acute colleagues as to why they aren't cash releasing if they are releasing a ward. Yes, they may be applying for additional funding to do further investment in reducing waiting lists, but actually it cannot be stated that these are not cash releasing if there was an intent to left shift, which is the ICB's shift.
Yeah.
Robert?
Sorry. Robert may want to come in first with the discussions about the funding, and I'm happy to talk about the recruitment. Yes.
Yeah, so it's yes, Martin, we are actually recruiting substantively at risk because actually it would be not very cost effective to try and do it on agency, obviously counters lots of other reasons, and we probably wouldn't get them anyway. It's a pretty modest amount. It's around about 100k part year effect. So we're not talking, vast numbers. We're talking about 4 members of staff here. Overall, all of the staff we've got in the pilot, we did recruit substantively at risk. So we're in those discussions with partners, and as Matthew says, I don't think it's the issue about whether it is the right thing to do and releasing a saving. It's about, is that a cashable saving, or how do you make it cashable? So those are the discussions that are going on.
Thank you, Robert. And I think I could see a little bit of Martin's tongue in his cheek when he talked about releasing cash from, as we know, our acute trusts are already significant potential deficits, which they're trying to deal with. But the point is very well made, Sue.
Yeah, just a follow-up to that funding one. for the urgent care response, which again I think is a brilliant initiative, the staff were feeling that they were doing that without extra staffing, and so that they felt they were bearing the brunt of the initiative, although they also thought it was a brilliant initiative. So I do think that whole funding issue and needs resolving, because I think people are going to be left feeling aggrieved if they're picking up what they perceive to be pieces and there's no additional money for it. But my main point was really to do with Hillcrest. That's amazing that you've got that staff response, and very pleasing. I suppose one of the issues is you've got a lot of block book staff there. Those block book staff than to be putting people out of region, and so it is a cost-effective proposal that people are coming up with, or is it a bit just it's more just because of convenience and it's what carers and families want?
The balance of cost is actually probably pretty even. The block book staff that we've got are a substantial portion of staff that are deployed on Hillcrest. We don't have to increase the staffing level to move from 10 to 14 beds. So at the moment it's staffed up as if it were in that bed range anyway. The major benefit that arises from having 14 beds is that means that there are 4 people who are having care close to home, where people can visit them. They're still in contact with local community resources and services, and will probably get discharged earlier from the bed as well. So that's the main reason for doing it. We want to make sure we're doing it properly. One thing I would say is that a condition that we've agreed is that we won't open another bedroom corridor. So we're trying to keep the footprint as small as we can in Hillcrest. That means only having 2 7-bedroom corridors open. But what it does mean is that we can't have more than 7 males or more than 7 females, because if we do, we start mixing genders on the bedroom corridors, which we won't do. So that does provide some constraints around it. And as I said, it'll be the clinical professional advisory group that signs off that proposal.
Thank you, Matthew. And just to conclude Matthew's paper, for board's information, this is more good news on Hillcrest, which Matthew's unaware of, because I was aware at NHS Providers Conference this week, and as you would expect, I had a number of conversations. One of them was with a non-executive director from another trust, and it came out in the conversation. In fact, she specifically said to me, because she's a psychiatrist, and she said, "Oh, I've been on one of your wards, Hillcrest." And so I sort of steeled myself a little bit to because she was carrying out an activity. I wasn't sure. I think a second doctor opinion or so. I forget what it was, but she was there for a formal activity. And she said, I was most impressed with the manner in which your staff engaged with the patient cohort. I sat and watched on the ward for 2 hours as part of whatever she was doing there. And she wished to specifically bring to my attention, I think the chief executive was with me at the time. She wished to specifically make the point that she was impressed with the manner in which the staff engaged with the patient cohort there. So bearing in mind what we've been through over the last 18 months, it was really positive to hear that from a completely independent and non-sought out comment. It was really pleasing to hear, Matthew, and I hope that brings a little bit of joy to a very difficult situation you've dealt with over the last 12-18 months. Matthew.
Thank you. That is gratifying to hear. I mean, one thing I would obviously draw people's attention back to that is that we've talked a lot about culture, haven't we, and cultural improvement. And one thing that we've worked very hard on at Hillcrest is getting the right leadership team in place with the right competencies and supporting them to deliver. And it really is the leaders that we now have on and around Hillcrest Ward that have made the significant difference here.
Yeah, I think that's a message to every area, isn't it? Thank you, Matthew. If we can note that report and we move to a quick update on where we are with our flu vaccinations. And Hannah, I assume you're taking this on behalf of the boss who's elsewhere.
Yes, thank you. So the paper that you've got provides the plan for the staff flu and COVID immunisation campaign for this year. It provides some assurance of the robust plan that we've got in place, which we develop against a national best practice checklist for implementation. I won't go through the detail of that. The plan is obviously well underway now, and I invite any questions on the paper.
Janet.
Yeah, thank you for the plan. It looks very comprehensive. My question is around a trajectory. If we're going to have to get to 80% by the end of February, do we have and we know where we are now, I think, do we have a trajectory, I struggle with that word, for how we're actually going to get there, please?
Thanks, Janet. There are trajectories in place around the target. Our real focus is what happens over the next 4 weeks. So we've got we know that the later in the season, as such, that those flu injections are received by our staff, the less effective they potentially become. So yeah, the next 4 weeks are our real optimum period of where we're trying to get up to that 80%. Staff teams are receiving a weekly breakdown of where they are as individual teams, so that we can manage trajectories kind of at that individual level, as well as what's happening as an overall trust. So there's some real close monitoring going on of the data. We're not alone, unfortunately, in some of the challenges we're having against those trajectories. So we still see the impact of all of the usual things around people receiving immunisations, but this kind of immunisation fatigue as well that's come on board in the last couple of years. So we're not alone, but again, we're working closely with our partners at the Acute Trust to talk about what's working for them, how can we learn some lessons and really make progress on those trajectories.
Yeah, thank you, Hannah. Robert.
Yeah, I suppose it was just to probably specifically answer the question, Janet. I think we're a little bit behind where we expected to be at this point. We had a very good discussion at senior leadership team meeting on Tuesday, where we had quite an open conversation with Hannah and sort of some additional kind of feed in from others around what we might do. There are all the challenges referred to, but yeah, it's going to need to be a real focus for the next few weeks. We're certainly targeting trying to get some real momentum over the next 2-3 weeks, wasn't it, Hannah, before the end of this month? So, yeah.
Yeah, thank you, Robert. And for any staff or indeed public that are watching, for information, the board came together to receive our flu vaccinations collectively a month ago, and as administered by our chief nurse who had a needle in her hand. And I think one of the previous deputies that was doing some work for us. So we've had those, and to reminder to all staff and people on the screen that the COVID vaccinations are also available and they're disseminated across our trust. And I encourage all staff and indeed people on the screen, if you haven't already, to get your COVID vaccination as well. Okay, thank you, Hannah, and thank you for that update. Colleagues, should we take a quick break? We've been on the screen now. I say quick, I'm a generous person. So should we say 11 o'clock and then we'll catch up some pace afterwards to give you time to refresh your cups? Thank you. I'll see you at 11.